All right, folks, name's Hippocrates.terra, and I'm going to talk to you today about renal embryology and physiology, renal anatomy, as well as renal pharmacology and renal pathology. So buckle up, it's going to be a bumpy ride. First, let's discuss embryology. The big things you need to know for step one and level one is that there are three sections to the embryonic kidney. There's the pronephros, the metanephros, and the mesonephros. So the pronephros, this is visible at week 4, and then it degrades pretty early on. The mesonephros, this is in the middle, meso mean middle, and this functions as a kidney for the actual fetus, but it changes function after the first trimester, especially in male. It becomes an important part of the Wolffian system. The metanephros, this is where our kidneys actually come from. This develops at the 5th week of gestation, and it continues to develop in a process called nephrogenesis through to 36th week of gestation. There are a couple of parts to it. The first part being the ureteric bud, which is actually a bleb off of, well, I'll say a stem, how about, off of a mesonephric tunnel called the mesonephric duct. So this tunnel is very similar to the ureter, right, in a developed human. The ureter is this hollow lumen that allows the fluid to flow through, just like the mesonephric duct in the first trimester fetus, or second trimester, the fetus. That's the mesonephric duct. And then the ureteric bulb, it connects to that mesonephric duct and is the progenitor to the ureter, the ureteric pelvis, the calyces of the kidney, the collecting ducts of the kidney even, and it's fully a canal at about week 10. So again, it starts developing at week 5, the ureteric duct, and just like the metanephros, and then it's fully developed, the ureteric bud is fully developed by week 10. The metanephric mesenchyme, also called the metanephric blastema, this is the progenitor to most of the nephrons. So most of the nephrons, well, how about this? Most of the parts of all of the nephrons, right? So it's the progenitor to the glomerulus, as well as the proximal convoluted tubule, the loop of Henle, and the distal convolute. But remember that the collecting duct is part of that ureteric bud. So if there's a mistake in the interaction of these two tissues, the metanephric mesenchyme, i.e. the metanephric blastema, and the ureteric bud, then a bunch of kidney conditions can develop, such as multicystic dysplastic kidney or renal agenesis. Either of those may develop if there is a problem in the interaction between the ureteric bud and the metanephric blastema. It should be noted that the ureteropelvic junction is the last site to canalize, and because of that, it's the most likely place for a problem to develop. So if there isn't fluid pumped through this system, there isn't going to be enough water in the amniotic sac, and that's a condition called oligohydramnios. Oligo meaning little, and hydramnios pertaining to the water of the amnion. So too little fluid that the baby is bathing in. So what ends up happening is this condition called Potter's syndrome, also known as Potter's sequence, where there is compression of the fetus, physical compression, it's leading to deformities. You know, if it's compressing the face, you can have facial feature deformities. If it's compressing the limbs, you can have limb deformities. Really, that's the basis of it. The really serious ones, obviously, are if the chest is compressed, then the lungs can poorly develop, and that can even cause death in some of these patients. Now, there are some conditions that should be associated with this. A couple of buzzwords here. So causes for Potter's syndrome include ARPKD as well as obstructive conditions in utero, bilateral renal agenesis, or chronic placental insufficiency. So there's a little mnemonic that says babies who can't pee in utero develop Potter sequence, right? So pee and Potter. Baby can't pee, Potter, pee, Potter. Otherwise, some gestational defects of the kidney include horseshoe kidney. So horseshoe kidney happens when the inferior poles of the kidney are fused abnormally, right? So that's characteristic U shape. And what ends up happening is because of the differential growth that occurs in the body, normally the kidneys should go from just next to the bladder, and then the body will grow faster in between the kidney and the bladder. So it kind of brings the kidney up in relation to the bladder. So as the development goes on, the kidneys originally receive blood vessels from the aorta right next to the common iliac artery, the common iliac arteries. So if they don't split, then they stay right around that region, at least at the bottom part. So the ability to climb is impeded, and therefore you may see the renal arteries coming off of the aorta at a point that you wouldn't normally see. Furthermore, they get trapped below the mesenteric artery. This condition is associated with hydronephrosis, renal stones, infection, and chromosomal aneuploidy, like Turner syndrome, trisomy 13, 18, 21, and it's even associated with renal, but that's more rare. It's important to be able to distinguish this condition on a CT scan. So what you'll see is an abnormally shaped kidney that is joined, that crosses midline, and there's only one of them. So this joining should be at the level of just intestine, right? So it's pretty low in the abdomen. You won't see it, you just look at the top. Otherwise, some babies are born with a solitary functioning kidney, just one kidney, and that's the condition. It's called congenital solitary functioning kidney. So the majority of these folks are asymptomatic, and they have a compensatory mechanism where the one functioning kidney is hypertrophy. This is often diagnosed prenatally. There's also unilateral renal agenesis, where the ureteric bud fails to develop on one side and induces differentiation of metanephric mesenchyme, leading to a complete absence of the kidney and ureter. So this is both the kidney and the ureter. There's also multicystic dysplastic kidney, where the ureteric bud fails to develop, and it fails to induce differentiation of the metanephric mesenchyme, leading to a non-functional kidney that has cysts and connective tissues that are out of whack. This too is usually unilateral, but if it's bilateral, remember this leads to Potter syndrome. There's a condition called duplex collecting system, which is a bifurcation of the ureteric bud before it enters the metanephric blastema, creating a Y-shaped bifid ureter. The duplex collecting system can alternatively occur through ureteric buds reaching and interacting with a single metanephric blast. It's strongly associated with vesicoureteral reflux and or ureteral obstruction, and it conveys an increased risk for UTI. Posterior urethral valves, on the other, are membrane remnant in the posterior urethra in a male. These posterior urethral valves develop because the presence of these membrane remnant can lead to urethral obstruction. This too can be diagnosed prenatally, but it's prenatally diagnosed by hydronephrosis in accompaniment with dilated or thick-walled bladders on ultrasound. It's the most common cause of bladder outlet obstruction in male. So there are a couple parts to the adult kidney that I want to discuss. First, we have the renal artery. This comes in to the middle of the kidney, right just anterior to the renal vein, and even more anterior when compared to the location of the urethra. So from anterior to posterior, there's the renal artery, then the renal vein, and then the ureter. So these all come into the middle of the kidney, and then the renal artery, it starts to branch into something called segmental segmental artery. And there are about six or so segmental arteries. And then these segmental arteries, they split even further. They duplicate to about 12 interlobar arteries. And these interlobar arteries, they'll wrap around the structure called the medullary pyramid. And when they're on the superior or more superficial side of the medullary pyramids, these arteries are now called arcuate arteries. And then these arcuate arteries give off bristle-like smaller arteries called interlobular arteries. So don't confuse interlobar, which are bigger, and interlobular, which are smaller. So lobule is a diminutive to lobe. Lobule means small, so interlobular is smaller than interlobar. Okay, so then these interlobular arteries, they branch even further into afferent arteriole, which then feed into the glomerulus. And this is where filtration into a structure called Bowman's capsule, which we'll get to. So this capillary bed in the glomerulus reconstitutes into a single arteriole called the efferent arteriole. And then that efferent arteriole, which is really a portal system, it branches again into another capillary bed around the loop of Henle and the other parts of the nephron. The arterioles that wrap around the loop of Henle in particular are called vasorect, whereas if they wrap around a more cortical structure, it's called a peritubular capillary. And then this portal system goes into the venous. So after that second capillary bed, now it's called venules. The venules have similar naming structure. So there's arcuate interlobular venule, then there's arcuate vein, and then there's interlobar vein, and then there's segmental vein, and then there's renal, and that feeds into the IVC and up to the heart. So that's the blood flow. Let us now talk about some of these structures that I meant before from the outside to the inside. So on the outside, there is a renal cortex. Actually, even farther outside, there's the renal capsule. The renal capsule is very thin, fibrous, and it isolates the kidney from the peritoneal space, or rather the retroperitoneal space. And then just inside of the capsule, there is the cortex, which is where the glomerula and the Bowman's capsule, as well as the proximal and distal convoluted tubule, and the earliest phase of distal collecting duct of Henle are located. This section has a relatively isotonic environment with blood, and that's juxtaposed to the medullary pyramid, which have a very concentrated ionic solution, which is important for the gradation between the filtrate in the nephron and its surrounding environment in tonic terms, meaning because the medulla is super salty, you can actually filter stuff. It's really important for that to be the case. Okay, so let's briefly trace our way through nephron. So there's Bowman's capsule, which has a couple of different layers. The first layer to discuss is the one that's most intimate with glomerulus. This layer of cell is the basement membrane. That's part of the glomerular filtration barrier. Other parts of glomerular filtration barrier are the podocyte, which is considered the visceral layer of the glomerular filtration, and they just sit right on top of the basement membrane. And these things look like essentially a comb, interdigitated, the teeth of the comb locked into interdigit with each other, and they allow filtration to occur while barring large molecules from entering into the filtrate, or at least limiting large molecules in normal circumstances. Otherwise, there's endothelial cells of the actual artery, which are arteriole and capillary, which also act as important parts of the glomerular filtration. Okay, so that makes up, let us not forget the mesangial cells, which are just kind of structural cells inside of Bowman's capsule that allow for the shaping of the glomerulus. These are hardly distinguished from juxtaglomerular cells, though they are distinct in certain ways that I'll get to. So just on the other side of those podocytes lies the filtrate, this luminal space. And the lamin of that are the podocytes, that glomerular filtration barrier, interior, and then on the outside there is the parietal cells of the Bowman's capsule. And there's an opening to Bowman's capsule directly opposite of where the arterioles enter and exit. That is the proximal convoluted tubule. So the proximal convoluted tubule is the first place where reabsorption and secretion occur. We'll get more on that in just a moment. And then comes the Henle, and then comes the distal convolute, which houses the macula densus, that are very intimate with the afferent and the afferent arteriole, though there is a layer of juxtaglomerular cells that separates. Okay, so that's the gross overview, and it's important to be able to distinguish these segments on a electron microscope image. Onto the parts of the urinary system anatomy that come from the ureteric bud. So the collecting duct is the first part of that, and then these collecting ducts coalesce into minor calyces, and then those minor calyces coalesce even further into major calyces, and then they all coalesce into a structure called the renal pelvis, and then the renal pelvis leaves the kidney and is called the ureter. The ureter then goes to the bladder, and on its way to the bladder, it travels underneath the gonadal artery and over the common iliac artery, and then under the uterine artery, or the vas deferens. This is easily remembered by the silly mnemonic water, or the ureters, flows over the iliacus and under the bridge. So flows over the iliacs and under the uterine artery, or the vas deferens. Now, why is this important? This is anatomically important because gynecological procedures like ligation of the uterine or ovarian vessels, they can actually damage the ureter, leading to ureteral obstruction. Something to note about its physiology is that it has muscle fibers that are inside of the wall of the ureter, and that prevents urine from refluxing back up. And there are three places where stones get caught in this system most frequently. The first one being the uropelvic junction, especially in the case of uric acid stone, as well as the pelvic inlet and the urethrovesicular junction. Now, this is the case because as the ureter enters the bladder or the vesicle, there is this pressure close valve. So as the bladder fills, there's a natural pressure that pushes against the flap overlying the os of this junction, and it will prevent the bladder from overfilling before the individual can initiate urination. But that mechanism works to the individual's detriment in the case of kidney stones, because that sharp angle and that flap can actually catch the kidney stone due to the decrease in luminal volume at this junction. So now I want to briefly talk about the anatomy of the bladder. First thing to note is that there is, on the top part, something called the median umbilical ligament that connect bladder anterior, superior to essentially the skin. And this is a remnant of urachus, where urine flowed out into the allantois. Around this umbilical ligament is a thick muscular wall called bladder wall, and the top muscles are called detrusor muscles. Now, towards the bottom of the bladder and towards the middle is where the ureteral orifices are located, as well as the urethral orifice. And the triangle between these three holes, remember, two ureteral and one urethral, is called the trigone. And this is smooth compared to the rugated detrusor area. And then there's the urethra, which males have a prostate that circumvelops the proximal end of the urethra, and that urethra travels through the pelvic diaphragm, penis, terminating at urethral meatus. In females, the urethra is much shorter and terminates in the antrum of vagina. So now I want to talk about the fluid compartments of the body. So moving away from anatomy and on to the physiology, fluid compartments. Now, so the body is largely water, and the kidneys do most of the filtration of the water, and excretion, I should say, of this water. So most of the body mass is indeed water, and that's about 60%. 40% of that, so 60% of the body is water, right? So about 2/3. And again, about 2/3 of that volume, the total body water, is intracellular, whereas 1/3 is extracellular. And of that 1/3 that is extracellular, we have 1/4 of that is actually in the blood, whereas 3/4 of that is in interstitial fluid that's difficult to access by medical providers. Blood is easy to access, whereas interstitial fluid and intracellular are much more difficult to access. But luckily, we can predict conditions in these other compartments, i.e. the intracellular fluid and the interstitial, by what we see on our lab values because of predictable osmotic and channel. Now it should be noted here that plasma volume can be measured by centrifugation of the blood and radioalbumin, and extracellular volume can be measured by inulin or mannitol assays. And normal osmolality should be just under 300, should be around 285 to 2 milliosm per kilogram. So one more comment on the glomerular filtration barrier. We have most of the, say all of the plasma gets filtered through this system at some point, and it selects for things based off of size and charge. It's composed of fenestrated capillary endothelia. It has a basement membrane with type 4 collagen, as well as heparin sulfate. It has an epithelial layer that has the podocyte foot process, and it has a charged barrier where all three layers of it, these fenestrated capillaries, the basement membrane, and the epithelial, contain negatively charged glycoproteins that preserve negatively charged molecules in the circulation, such as albumin. Another way of saying that is they prevent the filtration of negatively charged molecules like albumin. And then these fenestration and the podocyte foot process prevent entry of molecule greater than 100 nanometers and 50 to 60 nanometers respectively. Onto some of the equations that are used in renal physiology. First, I want to discuss renal clearance. So clearance of substance F equals the urine concentration of that substance measured in milligrams per milliliter times the volume flow rate measured in milliliters per minute divided by the plasma concentration of substance X, again in milligrams per milliliter, just like the urine concentration. So if you work this out, the clearance of substance X is in milliliters per minute because these milligrams disappear and the milliliters disappear in the urine concentration and the plasma concentration, just leaving the volume flow rates units. So what is this measurement? What is this telling us? It tells us the volume of plasma which the substance is completely cleared of per unit time. So if the clearance of substance X is greater than the glomerulofiltration rate, then there's a net tubular reabsorption of substance X, right? So if we're clearing less than we're filtering, then we must be reabsorbing it somewhere along the nephron. Conversely, if the clearance is greater than the filtration rate, then there must be a net secretion of substance X. So there must be a channel that is on the nephron that transports it from the vasa recta or the tubular capillaries into peritubular capillaries, into the nephron, naturally, right? And then if it's equal to the GFR, that just means that there is no net secretion or reabsorption. So secretion and reabsorption equal each other, but they don't necessarily equal. So I use this term GFR. What is GFR? Glomerular filtration rate. So glomerular filtration rate, it's a measure of how much substance being filtered from the glomerula into the bone and space. We often use inulin as our gold standard molecule because inulin does not get absorbed or secreted and it's freely filtered. Further, it has little toxic to no toxic effect on the body, and it's not degraded at any other point, such as the liver. So all of it gets freely filtered, and it's a really good measure. The only thing is that this is an expensive test because you have to take blood inulin concentration and urine concentration, and that's just so we often see this measure called eGFR, which I'll get to. So back to the actual measure of GFR. It's the same thing as the clearance of a substance, but specific to inulin. So it has that that same equation. GFR equals the urine concentration of inulin times the volume flow rate of the urine over the plasma concentration. Otherwise, this can be theoretically thought of as K sub F, i.e. the filtration coefficient, times a polynomial subtraction, right? So KF times the resultant of, in parentheses, hydrostatic pressure in the glomerular capillaries minus the hydrostatic pressure in the Bowman space, close parentheses, minus, open parentheses, the oncotic pressure of glomerular capillaries minus the oncotic pressure of the Bowman space, close parentheses, where the oncotic pressure of Bowman space is normally equal to 0. So again, it's K sub F times that big subtraction thing that I said, and that's normally equal to about 100 milliliters per minute, which is a lot. Think about a 2-liter bottle of Coke. If all of what you're filtering out were to be not reabsorbed, then we'd be peeing out a 2-liter bottle of Coke every 20 minutes. Luckily, most of what we filter is reabsorbed. So like I was saying just a second ago, inulin is the gold standard for a laboratory assay of GFR. However, creatinine clearance is a good approximation, though it may slightly overestimate GFR. And this value is very important because even small reduction in GFR are pathognomonic, I should say, for chronic kidney disease, though creatinine varies based off a person's habit. So Arnold Schwarzenegger, for instance, who had large amounts of muscle, would be creating large amounts of creatinine compared to, say, Stephen Hawking, who had markedly less body muscle and therefore produced markedly less creatinine on any given day. So that should be taken into consideration when evaluating someone's GFR. And most laboratories take into consideration many factors such as age, race, gender, and other conditions that affect creatinine levels. Other equation that starts with a little e is the effective renal plasma flow. So this is written little e, capital R, F. And effective renal plasma flow is estimated by using a chemical called para-aminohippuric acid, or PAH, and evaluating that chemical clearance. So it's an estimate. And we use this chemical because PAH is nearly 100% excreted in the kidney, and it's all taken care of better than any other chemical that we can economically deal with. So it's filtered and secreted at nearly 100%. So it gives us a decent assessment of our maximum plasma flow, let's say. It's our ceiling, and we call that effective renal plasma. And a better marker would actually be the clearance plasma, but that's the water we're swimming in, so it's tough to measure that. Our best proxy is the one that's really, really well filtered. Okay, so again, we use the clearance equation, which is urinary concentration of PAH times the volume of urine divided by the plasma concentration PAH, and that gets us the renal plasma. Now, the difference between the renal plasma flow and the renal blood is essentially how much of that blood is red blood cells, right? So the equation for it is renal blood flow, or RBF, equals the renal plasma flow, RPF, divided by 1 minus the hematocrit. So that's a polynomial denominator. So it's what's left over when you take away, the red blood cell. 100% minus the percent that is the red blood cells, also known as the hematocrit, and voila, you have renal blood flow as a functional number. Let me state that equation again just for clarity. That's RBF, renal blood flow, equals RPF, renal plasma, divided by parentheses 1 minus the hematocrit, close parentheses. And usually this value is about 20 to 25% of the cardiac output. So conceptually, about 20%, maybe a quarter of our blood goes to our kidneys per. Now you may be wondering, why did I use that 1 minus hematocrit? And it's because the plasma volume equals the total body volume times parentheses 1 minus hematocrit, close parentheses. So if one just takes this equation and instead of considering the total plasma and the total body or total blood volume, instead we just use that same equation and look at renal stuff, then we get that previous equation. So looking at filtration, there's an equation for that as well, where filtration fraction, or FF, equals the glomerular filtration rate divided by the renal plasma. So it's simply a fraction of how much is being filtered over how much plasma is actually getting there. Normally, about 20% gets filtered, and the filtered load of any substance is the filtration rate, the glomerular filtration rate, times plasma concentration of that substance. So the filter load is proportional to the concentration. The thing about filtered load is it's a mass rate, where it's milligrams per minute compared to milliliters per minute that we've seen in all of the other equations. So a couple of different conditions change these values. Physiologic responses, as you would expect, change the glomerular filtration rate, renal plasma flow, and the filtered fraction, the filtration fraction. So if you constrict the arterioles leading to the glomerulus, as you might expect, you'll see a decrease in the GFR, glomerular filtration rate, because not as much is getting there. You're also obviously going to see a decrease in the renal plasma flow, because again, not as much is getting there. And because you have a decrease in both of the numerator and the denominator of the filtration fraction, you get no change to the filtration fraction. If, on the other hand, you decrease the diameter of efferent arteriole, what ends up happening is there's a backup, essentially, in the blood at the glomerulus. And so the oncotic pressure in the glomerulus increases, or the hydrostatic pressure increases, and the filtration rate, therefore, increases. More filtrate comes, despite the fact that there is a decrease in renal plasma flow. So when there's efferent, aka distal arteriolar constriction, we have an increase in the filtration fraction because the numerator, the GFR, increased, and the renal plasma flow, or the denominator, that one decreased. So this is what's going on when we give a patient an ACE inhibitor. It preferentially constricts the efferent arteriole, whereas a prostaglandin, like an NSAID, will actually preferentially act at the afferent arteriole. But the way the prostaglandin acts is in a vasodilatory manner. And ACE inhibitors, again, are vasoconstricting. ACE inhibitors act by decreasing the function of angiotensin II, which is vasoconstricting, obviously, right? ACE inhibitors are hypertensive drugs and are useful simply because they vasodilate and stop the function of angiotensin II. So the mnemonic to remember that is PDA. Prostaglandins dilate afferent arterioles, and ACE. So angiotensin II constricts efferent arteriole. Easy. This should make sense intuitive, really. What might make a little bit less intuitive sense is what happens if you change the plasma protein concentration. So if you increase the plasma protein concentration, you'll have a smaller GFR, but you won't change the renal plasma flow. And therefore, you'll decrease the filtration fraction. Whereas if you have a higher, or if you have a lower plasma protein than normal, one would expect an increase in glomerular filtration, no change in plasma, or negligible, and therefore a increase in the filtration. Now, what do you think would happen if you constrict the ureter or had a stone? If that were to happen, GFR would back up, or would decrease because there's a backup in the bone and space, but the renal plasma flow would stay the same. And obviously, the filtration fraction, or is decreasing numerator, that one too is going to increase. And what happens with dehydration? With dehydration, the renal plasma flow is the driver here, where you have less plasma getting kidney. Therefore, you have less filtration occurring. And because the plasma flow is decreasing more than the filtration, one would expect a slight increase in filtration fraction. Let's move on to calculation of reabsorption and secretion. So again, filtered load is GFR times plasma concentration of X. The excretion rate is the volume of urine times the concentration of substance X in the urine. And that makes sense. The excretion is your urine times the concentration in the urine. Substance. Reabsorption rate is what what's being filtered minus what's being excreted, and that only works as a net value, and it only works if more is being filtered than being excreted. Otherwise, if more is being excreted than is being filtered, you measure the net secretion rate. One of the really important molecules that we look at for excretion rate is sodium in an equation colloquially called the FeNA, fractional excretion of sodium. And as you would expect, this is the excretion rate of sodium over the filtration rate of sodium, or the filtered load of sodium. So to put that in variable terms, we have V, volume of urine, times the urine concentration of sodium divided by the glomerular filtration rate times the plasma concentration of sodium, V times U over GFR time. And if GFR is equal to that creatinine equation we had for, you can simplify the FeNA equation to plasma concentration of creatinine times the urine concentration of sodium divided by the urine concentration of creatinine times the plasma concentration of sodium. And that's parentheses P times U over parentheses U times P. Now, we discussed this one, FeNA, because it's super important, as we'll see in a bit, when we are talking about assessing acute kidney injury. So is this injury occurring at the level of the glomerulus, or is this and the nephron itself, or is this injury occurring in the arterioles and artery system, the vascular system? Or is this a post-renal injury? Is it happening in the ureter or the bladder? So FeNA will come back in that. It's very important there. But let's talk about glucose clearance briefly. Glucose is normally completely reabsorbed in the proximal convoluted tubule by sodium glucose cotransporters. Normal plasma levels of glucose range from 60 to 100 milligrams per deciliter, depending on how long someone has been fasting for. In adults, plasma glucose of about 200 milligrams per deciliter is pathognomonic for diabetes, and that's the threshold where glucose can start to be seen in the urine. And when it gets even higher at about 370 milligrams per minute, all transporters are completely saturated with glucose, and there starts to be a linear relationship between plasma glucose and quantity of glucose in the urine, concentration of plasma and concentration of urinary glucose. Now, this isn't for all normal healthy individuals. One notable exception is in the condition of pregnancy. Pregnancy is associated with an increase in filtration rate. So with an increase in filtration of all substances like glucose, the glucose threshold can actually be at a lower plasma concentration. Otherwise, if someone is taking a sodium glucose cotransporter 2 and an S-glut, like the Flozin drug, one would expect glucosuria at plasma concentration less than 200. As a matter of fact, that's the function of the drug. Otherwise, glucosuria, it's an important clinical tool for assessing whether someone has diabetes or not. And it's really quite rapid. If you see that on a urine stick, then one can begin treatment of an unconscious patient who came into the ER with fruity breath. So there's this term called the splay phenomenon, which is what we described verbally, where the maximum Tmax, the maximum threshold for these sodium glucose cotransporters, it's actually reached gradually rather than sharply, because there's a bunch of different shapes to nephron. And so these transporters actually have slightly variable Tmaxes, and that can be seen on this curve by a bend curve. So now let's take a moment and start to dive into the physiology of the actual nephron itself on a channel basis. So starting in the early proximal convoluted tubule, we have a couple really important channels on these brush border cells. So it's a brush border first, and that means there's a lot of surface area. And at this brush border, we can see a reabsorption, ideally, of all glucose, amino acids, and most bicarbonate, sodium, chloride, phosphate, potassium, water, and uric acid. So virtually all glucose and large amino acids, or amino acids more broadly, and then most of the ion. Remember, water follows sodium. So if we're reabsorbing a bunch of sodium, then we're also going to be reabsorbing most of the water. Furthermore, the proximal convoluted tubule generates and secretes NH3, which allows the kidney to secrete even more even more hydrogen, so more acid. This NH3 binds with H plus to create ammonia, or NH4 plus. Otherwise, there are a couple of really important cells that transport protein, that act on the apical and basement membrane of these cells that allow for this transport to occur. One of them being a sodium potassium ATPase that happens at the basement membrane, or the basolateral membrane of these brush border cells. So these pump 2 potassiums into the cell and 3 sodiums out of the cell. And that's really the only pump that we see on these cells. So this is the driver on these in this area. This is where the ATP is generating a chemical gradient, and then the rest of this stuff uses that sodium gradient, a low interstitial sodium concentration, to drive the rest of the reactions. So since there's a low interstitial sodium concentration, we see a sodium glucose cotransporter that we discussed before, that brings glucose out of the lumen and into those cells. We also see a sodium hydrogen exchanger, so an antiporter, that brings sodium into the cell and dumps hydrogen into the lumen against its concentration gradient. But that hydrogen that goes into the lumen, it can now bind with bicarbonate via a thermodynamically favorable reaction, or it can bind with bicarbonate using the catalytic enzyme carbonic anhydrase, and then that forms transiently carbonic acid, which then it dissolves into CO2 and H2O. This H2O can then travel through an aquaporin channel or be osmotically reabsorbed because it's following that sodium, so that carbon dioxide and the water, they can both passively get reabsorbed. Carbon dioxide as well, because it's a nonpolar molecule that can freely travel across the membrane. And then once it's on the interstitial side of these brush border cells, they can interact with carbonic anhydrase again to recreate carbonic acid, and that carbonic acid can then convert back into H plus and bicarbonate, and then bicarbonate will be able to be taken up into the body to contribute to the bicarbonate buffering system, if need be. That part is particularly susceptible to changes in the pH of the blood, so the acidity and basicity of or alkalinity of the blood in the rest of the body. So it should be noted that the lumen and the interstitium, as well as the proximal convoluted tubule, these cells remain in an isotonic and a relatively isotonic state. And final thing that I want to comment on is how chloride gets absorbed here. Because this bicarbonate is being reabsorbed and there's a slight imbalance of positive charges being pushed into the lumen compared to the interstitium, there is going to be an acidity to the urine at this point. So after the early proximal convoluted tubule, we can move on to the thick descending loop of Henle. So the thick descending loop of Henle, this passively reabsorbs water via medullary hypertonicity, right? So that medulla, the pyramid of the actual kidney, it has a very concentrated interstitial area. So there is passive reabsorption of water that occurs here. It is notable, though, that this area is in fact permeable to sodium. So this is a moment when sodium is not eating water, but rather water is traveling down a constant ionic gradient. If I said a thick descending, just came to my mind that if I said thick descending loop of Henle, I should have said thin descending. So the thin descending loop of Henle is the area that water is passively reabsorbed due to the medullary hypertonicity and impermeability of sodium, generating this concentration. And so this is where urine becomes very concentrated to match the salinity of medulla. This makes the urine hypertonic compared to serum. And then at the thick ascending loop of Henle, we get a reabsorption of sodium, potassium, and chloride, which indirectly induces paracellular reabsorption of magnesium and calcium through a positive luminal potential that's generated by potassium back. And this area is also notable for its impermeability to water molecules. So as you go up the Henle, there is a decrease in concentration of the urine or the filtrate. So again, the thick ascending limb, it reabsorbs sodium, potassium, and chloride. Indirectly, it induces paracellular reabsorption of magnesium and calcium generated through potassium back from the countercurrent exchange system that I'll get about in a minute. And at this area, 10 or 20% of sodium is reabsorbed. That's the numbers for sodium. So we've really pulled in quite a bit of sodium at this stage. It should be noted that the thick ascending limb, where loop diuretics such as furosemide act, it's on that sodium potassium chloride NKCC cotransport, or the NKCC transport. So what's happening is, again, the sodium potassium are at the basolateral member are the ones that are at transport, and everything else here secondary to that. So since we are pumping in potassium to intracellular, sodium we're pumping in tissue or the blood effectively. What ends up happening is sodium travels down its gradient into that cell from the loop, and then potassium, it has a chance to pass up into blood, and it also has a chance to pass up in the urine depending on the charge gradient at this part of the nephron. And then since usually it generates a positive potential in the lumen at this point, so the urine is acidic, let's say, or at least positively charged, what ends up happening is magnesium, calcium travel into the interstitium or into the blood effectively between the cells in what is called a back-leak mechanism. So in the early distal convoluted tubule, it's a different story. This is where thiazide diuretics act. So in the early distal convoluted tube, we see a resorption again of sodium, but more particular to this area is the marked reabsorption of calcium via a calcium-sodium exchange. Other things that are reabsorbed here are chloride. Those are the big ones. So this is the area that makes urine the most hypotonic. So it went from isotonic, hypertonic to more isotonic, and now this is the chance for it to be markedly hypotonic. So the way it does this, again, is with the sodium-potassium ATPase generating an ionic gradient, which pulls sodium out of the lumen into the cell via a sodium chloride. So not an NKCC, but rather an NCC, a sodium chloride cotransport. And that's how the thiazide diuretics act on that sodium chloride cotransporter. But what ends up happening is, since in the presence of thiazide diuretics, we inhibit that pump, a different pump comes into play where sodium gets transported. I use the word pump, I should have said transport. So sodium gets transported into the interstitial area via a sodium-calcium exchanger on the basolateral membrane. And so calcium is being pulled out of the epithelial cells, and then calcium gets pulled into the epithelial cells from the lumen to fill that void. Otherwise, chloride passively diffuses through chloride channels at the basement membrane, and that's left medicinally relevant. Moving on to the collecting duct. In the collecting duct, there's a lot going on. This is where sodium is reabsorbed for the last time, so with that same sodium-potassium ATPase. See it again. So that sodium-potassium ATPase is generating this gradient in these cells called principal cells. So these principal cells are generating that gradient and induce sodium reabsorption and potassium secretion And then because there's sodium reabsorption, we also have water reabsorption, as well as chloride reabsorption in between these cells via passive transport to equilibrate the charge gradient. Now, this charge gradient and the acidity gradient, more precisely, is modified by a different category of cells called intercalated cells. These intercalated cells come in two different types. There's alpha intercalated cells, which are acid generating, acidic urine generating, I should say. And then there's beta intercalated cells, which make the urine more basic. And now these two types of cells are essentially the same thing, but in reverse. So their channels and hydrogen potassium pumps are on opposite membranes, where the alpha intercalated cells pump hydrogen, or H+, into the urine, into the lumen, generating acidic urine, as well as passively exchange bicarbonate and chloride at the basolateral membrane. It's precisely the opposite in beta intercalated cells. Beta intercalated cells pump hydrogen into the body via an ATPase and have a bicarbonate exchanger at the apical membrane. So this is a very busy area for medical reasons. We have aldosterone, which amplifies both the alpha intercalated cells and the action of the principal cells. Does nothing for the beta intercalated cells. So if aldosterone interacts with the aldosterone receptor here, then we have more potassium excretion, more sodium reabsorption, more acidic urine, and more concentrated urine. Whereas if we inhibit these aldosterone receptors or inhibit the production of aldosterone, we inhibit the receptors with a chemical like spironolactone or inhibit aldosterone, then what we get is less excretion of potassium and less reabsorption of sodium, therefore more dilute urine and potassium, what's called potassium sparing, as well as a decrease in the acidity of the urine. Another drug, so that's aldosterone, and I addressed aldosterone inhibitors as well as spironolactone, which is an aldosterone receptor blocker. There's also ADH that acts here, and ADH binds to V2 receptors that are specific to the principal cells. So with ADH, we don't have as much manipulation with the ionic gradients. It's really stimulatory for the generation of aquaporin channels. So water can reach a better equilibrium inside of the cells with higher levels of ADH. So it reabsorbs water without affecting sodium, potassium, or hydrogen concentrations very much. The final drugs that I want to address in this area are amiloride and triamptorine, which act on a channel called ENaC, which is an epithelial sodium channel, ENaC. So these inhibit that sodium channel, leading to a negatively charged lumen and therefore allow for potassium wasting or potassium secretion into the lumen. That's all quite complex and nuanced, and I suggest evaluating it again. So there can be problems with the channels of these various parts of the nephron, and this can be easily remembered with a mnemonic. The kidneys put out fabulous glittering liquids. So fabulous is supposed to remind you of Fanconi syndrome and Bartter syndrome. Glittering is supposed to remind you of Gittleman's syndrome. The L in liquids is supposed to remind you of Little syndrome. And the S in liquids is supposed to remind you of SAME, or syndrome of apparent mineralocorticoid excess. So again, it's the kidneys put out fabulous glittering liquids, and these are this is especially convenient because the order of these words, Fanconi, is in it affects the proximal convoluted tubule. Bartter, which is the B in fabulous, affects the loop of Henle, specifically the ascending limb. Gittleman's affects the distal convoluted tubule, which is the next in line. That's also glittering in the mnemonic. Little syndrome is the next one. And SAME, or syndrome of apparent mineralocorticoid excess, these two affect the distal convoluted tubule. So more on Fanconi. What's defective in Fanconi syndrome is there's a generalized resorption defect in the proximal convoluted tubule, which leads to elevation in the excretion of amino acids, glucose, bicarbonate, phosphate, and all substances that are reabsorbed by the proximal convoluted tubule. What ends up happening is it can lead to a metabolic acidosis, specifically in the proximal renal tubule. So it's a proximal renal tubular acidosis. It can result in hypophosphatemia as well as osteopenia. So this can affect the bone. What causes it is hereditary defects like Wilson's tyrosinemia, glycogen storage. Ischemia is not a hereditary defect. The hereditary defects are Wilson's disease, tyrosine, and glycogen storage. Otherwise, it can be caused by ischemia, multiple myeloma, nephrotoxic drugs like phosphamide, cisplatin, platinum, and even expired tetracycline and lead as well. So Fanconi syndrome, again, proximal convoluted leads to something called a type 2 renal tubular acidosis or a proximal renal tubular acidosis. We'll get to. It can also cause hypophosphatemia, Bartter syndrome. This one is a resorptive defect in the thick ascending pendulum, and it affects the NKCC channels, that sodium potassium chloride cotransport. What ends up happening with this one isn't a metabolic acidosis like we saw in Fanconi. It's quite the opposite, actually. It's a metabolic alkalosis. This one we get hypokalemia and hypercalciuria. So the big differentiating factor of this one is hypocalciuria. The big differentiating factor for Fanconi is that there was a metabolic acidosis and a hypophosphat as well as osteopenia. So everything about Fanconi, Bartter syndrome, the real unique one here is the hypercalciuria with metabolic and hypocalcemia. Now Bartter syndrome is actually just an autosomal recessive that affects that, and it's very similar to diuretic or an overdose on the diuretic. So Gittleman syndrome, this is a resorption defect on the sodium chloride in the distal convoluted tubule. And just like Bartter syndrome, this one results in metabolic alkalosis with hypokalemia. But instead of being a hypercalciuria, what we see in fact is a hypocalciuria as well as a hypomagnesemia. Again, this one is autosomal recessive. And this one presents very similar thiazide diuretic. It's typically less severe than Bartter syndrome because remember, we're at a hypoosmotic area in the nephron. So it's okay if we're messing with this function because most of the business actually is going to take place in collecting duct, accounted for by that. So Little syndrome, this is actually a gain of function compared to a loss of function we saw in the other one, where we have an increase in the activity of sodium channel, which leads to an increased sodium absorption collecting. What ends up happening with this is a metabolic alkalosis, just like the previous two, with hypocalcemia, just like the previous two. This one presents with hypertension and a decrease in aldosterone. Now this one isn't recessive, this one is an autosomal dominant, and it presents very similarly hyperaldosterone, but aldosterone is nearly undetected. And we treat this with amiloride because it acts at that ENaC channel that's overactive. So again, the unique factors of Little syndrome are decreased aldosterone and hypertension. And then syndrome of apparent mineralocorticoid excess. This is a blanket term for a couple of different, where cells containing mineralocorticoid receptors are affected. So if we have defect in 11-beta hydroxysteroid dehydrogenase, which effectively turns cortisol into the inactive called cortisone. If we have a defect, then effectively we have too much cortisol. And what ends up happening is patient gets excess mineralocorticoid receptor activity, and that presents with the same presentation as Little syndrome and hyperaldosterone, i.e. metabolic alkalosis, hypokalemia, hypertension, and then it's different than hyperaldosterone in this way, but same as Little syndrome in this way, in that it has a decreased serum aldosterone level as adrenal glands try to compensate. Now this one is an autosomal recessive normally, but it can also be acquired from consumption of licorice, as a matter of fact, which contains a compound called glycyrrhetinic acid, and that blocks the activity of 11-beta hydroxysteroid dehydrogenase, that chemical, that enzyme discussed previously. So the way you treat this is by stopping them consuming true licorice, and then also it's autosomal recessive, treat them with potassium-sparing diuretic, which will increase the effect of mineralocorticoids. So it's important to think about the relative concentrations of the ions as they travel through the convoluted tubule. And the way we normally think about it is by looking at the tubular fluid concentration and comparing it with the plasma concentration. This is called the TF to P ratio. So if it's a 1-to-1 ratio, then that means this substance and water are reabsorbed at the same rate. And this is particular to the proximal convoluted tubule, I should mention. That's really where we see this graph discussed. So if it equals 1, that means that it's being this filtrate is being this filtered substance is being absorbed commensurate with sodium, for instance, and potassium are absorbed at a relative equal rate with water. If the tubular fluid concentration exceeds the plasma concentration, so the TF over P ratio is greater than what we see is a net secretion. Furthermore, if the substance's TF to P ratio exceeds inulin or creatinine, that means that the substance is being filtered and secreted. We see that with PAH, as we mentioned earlier. Now, on the other side of 1.0, so if the tubular fluid concentration is less than the plasma concentration, so the TF over P is less than 1, as we see with substances like glucose and amino acid, what that means is that the substance is reabsorbed more than water. So I'm going to touch on the renin-angiotensin-aldosterone system now and how it affects the fluid status and blood pressure of an individual. So if there is a stimulus like low blood pressure or low sodium chloride delivery to the macula densa cells, or there's high sympathetic tone, then the macula densa cells of the distal convoluted tubule signal to the juxtaglomerular cells to secrete renin. So renin then floods into the circulation, and this meets up with a hepatically produced compound called angiotensinogen. So renin then converts angiotensinogen to angiotensin 1, and then angiotensin 1 interacts with an enzyme that is produced by the lungs primarily called ACE, angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2. And now angiotensin 2 is an active molecule, and this acts on very many sites. It acts on the hypothalamus to stimulate thirst, as well as the posterior pituitary gland to stimulate the production of ADH. It stimulates aldosterone secretion from the adrenal gland, as well as sodium bicarbonate and water reabsorption at the proximal convoluted tubule, resulting in something called contraction alkalosa. Further, it acts at the glomerulus by constricting efferent arterioles. Remember, ACE, angiotensin 2, constricts efferent, which then results in an increase in the filtration fraction because it decreases the renal plasma flow and increases the glomerular filtration rate, which then, and then it also acts on receptors in the blood vessel, leading to vasoconstriction of the rest of the body as well, and that results in higher blood pressure. So these byproducts, these effects at the pituitary primarily have downstream effects on the principal cell. Just to backpedal a little bit here. So the ADH secretion, obviously, from what we were discussing before, though it's not obvious for anyone that hasn't spent time analyzing this, overusing the word obviously here. So the posterior pituitary affects those principal cells, like we mentioned before, and that primarily increases aquaporin and water. The aldosterone effects act at the principal cells, resulting in sodium reabsorption, potassium secretion, and aldosterone again acts at the alpha intercalated cells, resulting in hydrogen or H plus secretion. So you may be wondering, how does renin get the response from the macula densa cell? And the way it actually works is there's a decrease in sodium chloride delivery to these macula densa cells, which then changes the environment around juxtaglomerular cells as a response to this decrease in renal perfusion. And that will result in everything that we mentioned before. It can also be caused by increase in the stimulation of baroreceptors in the afferent artery. So it has multiple inputs. Something that's left out of this mechanism are two compounds called ANP and BNP. So ANP, atrial natriuretic peptide, is released from the atria, and BNP, another natriuretic peptide, is released from the ventricle in response to actual increase in volume. So these stimulate natriuresis, meaning the excretion of sodium and sodium and water in the urine. These act as a counterbalance to the renin-angiotensin-aldosterone, and they do essentially the opposite on the smooth muscles of the vasculature as well, where they increase cyclic GMP, resulting in an increased GFR and increased renin. But actually, that's not the only thing it does. These two chemicals, these natriuretic chemicals, they relax the smooth muscles in the afferent arterioles, but in reality, they also constrict efferent arterioles. So they promote natriuresis that well. Now, something unique about 88 is it primarily, this is the new chemical that we're talking about, a new chemical, ADH, and this one primarily regulates osmolality. Just like the RAS system, ADH responds to low volume status, and it stimulates the resorption of water in the collecting duct. Unlike the RAS system, this stimulates the resorption of urea in the collecting duct to maintain a corticopapillary gradient, and that's something that's unique. So the kidney also functions as an endocrine, where it secretes four chemicals: erythropoietin, calciferol, prostaglandins, and dopamine. So erythropoietin is released from interstitial cells in the peritubular capillary bed in response to hypoxia. This stimulates red blood cell proliferation in bone marrow. Erythropoietin is often supplemented in chronic kidney as well. Calciferol, or vitamin D, is produced when proximal convoluted tubule cells convert 25-hydroxy vitamin 3 to 1,25-hydroxy vitamin 3. So it throws on a hydroxy group at the 1 position, and it forms a compound called calcitriol, which is the active. This can be inhibited by parathyroid hormone. This can be amplified by parathyroid. Prostaglandin, these are paracrine secretions that vasodilate the afferent arteriole to increase renal blood flow. NSAIDs block renal protective prostaglandin synthesis, which leads to constriction of the afferent arteriole and a decrease in the glomerular filtration rate, right? This may result in acute renal failure in low renal blood flow state. NSAIDs are very contraindicated in low renal blood flow states. So you got to make sure the patient has good kidney function before you prescribe NSAID. And let's think back to the mnemonic we had before, which is PDA. Prostaglandins dilate afferents. Dopamine is the final kidney endocrine hormone. This is secreted by the proximal convoluted tubule cells, and it promotes natriuresis. At low doses, dopamine dilates interlobular arteries, as well as afferent arteries and efferent arterioles. Afferent arterioles, it's very dilatory. So this increases renal blood, but it has little change on GFR. Whereas at higher doses, this stimulates a vasoconstriction. So potassium shift is a very important concept because both hypokalemia and hyperkalemia can actually result in arrhythmias and be fatal. So luckily for us, we have an excellent mnemonic to remember what causes hyperkalemia, and that mnemonic is do labs with 2S. So what causes hyperkalemia is digitalis for do, hyperosmolarity, lysis of cells, such as crush injury or tumor lysis syndrome, that's L, lysis. Acidosis can cause potassium to shift out of the cells. Beta blockers can cause hyperkalemia. High blood sugar, or insulin deficiency, right? That can cause hyperkalemia, sugar. And succinylcholine can also cause hyperkalemia, and that's especially relevant for burns and muscle trauma. So what causes potassium to shift into the cell is largely the mirror reflection of what causes potassium shift out. So you can remember do labs as a workup for hyperkalemia, and then you'll already know what happens for hypokalemia. Instead of it being hyperosmolarity, it's hypoosmolarity. Instead of acidosis, it's alkaline. Instead of high blood sugar, such as seen in insulin deficiency, we can see hypokalemia when there's elevated insulin, as insulin shifts potassium into the cells, So that's the big potassium. Otherwise, we should be familiar with electrolyte disturbances more broadly. So when sodium is low, serum sodium is low, hyponatremia, patients will display nausea, malaise, stupor, coma, and seizures. When serum sodium is high, again, they can display stupor, coma, as well as irritability. Potassium, like we were mentioned before, when that is low, we get changes on EKG, such as U waves and flattened T wave, as well as arrhythmia, muscle cramps, spasm, and weakness. When serum potassium is too high, on the other, we can get EKG changes there where we have very high T waves called peak and widened QRS complex. Again, that's an arrhythmia, and see muscle here as well. It's the EKG there we distinguish, and then obviously the labs. Calcium, when that is low, patients can't control their muscles very well, and they get a condition called tetanus. They can get seizure, as well as QT prolonged twitching, which is called Chekhov's sign, and spasm, which is called Trousseau sign. When calcium's too high, on the other hand, we can see bones, stones, groans, thrones, and psychiatric overtone. So we can see renal calculi, bone pain, abdominal pain, urinary frequency, and anxiety, altered mental state. When magnesium, just like calcium, we can see tetanus, we can see torsades, so QT issues again. With this, we can also see hypokalemia and hypocalcemia. Those can often follow hypomagnesemia. When magnesium is too high, we can see decreased deep tendon reflexes, lethargy, bradycardia, hypotension, cardiac arrest, and again, hypocalcemia. Phosphate, when that one's too low, we can see bone loss, osteomalacia, and rickets. When it's too high, on the other hand, phosphate results in kidney stone, metastatic calcification, and hypocalcemia. Now I want to talk about acidosis and alkalosis and the distinction between metabolic and respiratory sources. So respiratory acidosis and alkalosis come when there is abnormal breathing pattern, whereas metabolic acidosis and alkalosis come from when there is abnormal excretion of bicarbonate, most frequent, or the consumption of an acidic compound. When a patient is suffering from an acidosis, obviously their pH is going to be low. That's the definition of acid. So when they have a condition that is leading to them being acidemic or having acidemia, we call it an acidosis, and vice versa for alkalosis. When they have alkalemia, the process leading to alkalemia is called an alkalosis. Now, there are a whole bunch of things that can result in a metabolic acidosis or a metabolic alkalosis, and those are what we're going to focus on in the renal discussion today. So what ends up happening with a metabolic acidosis is the relative concentration of HCO3 decreases, so the bicarbonate buffering system is out of whack there. And what the body tries to do to compensate is it tries to hyperventilate, thereby blowing off CO2, which is an acid. On the flip side, in an alkalotic state, a metabolic alkalosis, the body tries to increase CO2 to respond to the increase in HCO minus bicarbonate by hypoventilation. So when you see a patient, first thing that is unconscious. In both of these conditions, patient may very well be unconscious. So the first thing you do is get their sleep. Well, you check airway, breathing, circulation. And if we are concerned for an acidosis or an alkalosis, we then take their lab. So the pH comes back less than 7.35. Then we know it's an acidemia. Now, next thing we should do is check their PCO2. And if their PCO2 is low, then we know it's a metabolic acidosis. If their PCO2 is high, on the other hand, we know it's primary respiratory acidosis. Now, what is high? high. 40 is normal. So anything less than 40, we're going to be thinking it's a metabolic acidosis. And if it's anything greater than 40, then it's a respiratory acidosis primarily. And that's caused by hypoventilation. So they're not breathing enough. Problem. So we check their airway closely and we try to breathe for them. A metabolic acidosis, on the other hand, the next thing we do is check the anion. And so the anion gap is sodium concentration minus chloride concentration minus bicarbonate concentration. And what's left over is the anion gap, right? So the major cation is sodium. It's at 140 in a normal body. And then the two major anions are chloride, bicarbonate, and the rest of it call an anion gap. So that's what we're calculating. And if this gap is big, then we're going to think that then it limits our differential to only a couple of conditions, only a couple of things that can cause a widened anion. That list is mnemonically remembered by the word mud pile. So mud piles is short for methanol, also known as formic acid, uremia or uric acid or urea, diabetic ketoacidosis, diabetic ketone, that's D in mud pile. Propylene glycol is P. Iron tablets or ionate, those are 2 for I in mud pile. Lactic acidosis, lactate, is L. Ethylene glycol that's also known as oxalic acid, and salicylate is S. So these often end up with late. The most notable one is aspirin, ASA. Now a normal anion, again, these are only caused by a couple of different things, and this has a mnemonic as well. The mnemonic is hard ass. So this can be caused by hyperalimentation, Addison's disease, renal tubular acidosis, diarrhea, acetazolamide, spironolactone, and saline. So that's what we should be thinking with a metabolic acidosis that has a normal anion gap. So what is a normal anion gap? Normal anion gap is 8 to 12 milliequivalents per liter. So if the anion gap is small or less than 12, then we're thinking hard ass. If the anion gap is big or bigger than 12, we're thinking mud. Okay. Now what if it's an alkaline? That means the pH is going to be greater than 7.45. That's what an alkaline is. And now if the PCO2 is in the same direction as the pH is relative to normal, so if the pH is high and the PCO2 is high, then we know it's a metabolic syndrome. PCO2 is low, then we know it's a respiratory. So if the PCO2 is low, then we know it's respiratory alkalosis. And this probably means a person is hyperventilating, which can happen altitude sickness such as hypoxia, early salicylate use, as well as anxiety, tumor, and pulmonary emboli can cause a respiratory alkalosis. Whereas a metabolic alkalosis, this happens when the person loses a lot of hydrogen or is in excess of bicarbonate. That's what's most frequently causing. And it's often caused by loop diuretic, vomiting, antacid, or hyperaldosterone. Okay. So I want to dive into one of the normal anion gaps even further, that one being renal tubular, I want to dive more in depth into one of the metabolic acidosis that is a normal anion gap metabolic acid. That category, this category that I want to dive in more into is renal tubular acidosis. So there are 3 types of renal tubular acidosis. The first type being distal renal tubular acidosis, also called type 1 RTA. There's type 2 RTA, which is proximal renal tubular acidosis. And then there's type 4 RTA, which is hyperkalemic tubular acidosis. Now, these are poorly named, but that's fine. We'll dive into type 1 first. So type 1 is in the distal renal tubule, and this is a dysfunction of the alpha intercalated cell. These alpha intercalated cells, they can't secrete hydrogen, so no bicarbonate is generated, and that results in the metabolic acidosis. So what we see with this is a urine pH that's only slightly lower than body. So it should be a pH that's greater than 5.5. In this circumstance, the serum potassium should be low because of the Dulab's thing that we looked at before, where, well, that's not accurate. This is because at alpha intercalated cell, there is a pump, a potassium hydrogen ATA, that pulls potassium, that normally when it's functional, pulls potassium into cell, the alpha intercalated cell, out of the lumen. But if that's dysfunction, then potassium wasting commences. So a couple of things cause type 1 RTA, or distal renal tubular acidosis. One of them is amphotericin. Another is analgesic nephropathy. All right. So congenital abnormalities such as obstruction of the urinary tract and autoimmune disease like SLE, systemic lupus erythematosus, can cause. It's associated with an increased risk of calcium phosphate kidney stone due to an increase in urinary pH and therefore increased bone turnover. Proximal renal tubular acidosis, on the other hand, or type 2 renal tubular acidosis, is caused by a defect in the proximal convoluted tube bicarbonate reabsorption. So this results in an increase too of bicarbonate in the urine, which in turn results in a metabolic acidosis. But because the urine can still be acidified by the alpha intercalated cells in the collecting duct, the pH is going to be less than 55, but it's not going to be enough to actually overcome the increase in excretion of bicarbonate. So there's still this metabolic acidosis. In this circumstance too, we see a decrease in serum a decrease in serum potassium. This can be caused by Fanconi syndrome, multiple myeloma, and carbonic anhydrase inhibitors. It's associated with an increased risk of hypophosphatemic rickets, as seen in Fanconi syndrome, hyperkalemic tubular acidosis, or type 4 RTA, is a result of a defect in aldosterone signal. So this can be due to hypoaldosteronism or aldosterone resistance, and that results in hyperkalemia. And since there's hyperkalemia, we see a decrease in ammonium synthesis in the proximal convoluted tubule, and therefore a decrease in ammonia excretion. So in this circumstance, we can see low or variable pH, so about 5.5. And again, this is a hyperkalemic tubular acidosis. So in this one, the serum potassium should high. That's the differentiating factor. Now, this is caused by decreased aldosterone production, as seen in diabetic hyporenism, ACE inhibitor consumption, ARBs, NSAIDs, heparin, cyclosporin, or adrenal insufficiency. All of those cause decreased aldosterone production. Or it could be due to aldosterone resistance, as seen in potassium-sparing diuretic use, nephropathy obstruction, or trimethoprim sulfamethoxazine consumption. All of those can result in a type 4 RTA. So I'm going to stop right here, and it's been 3 hours, 40 minutes on my end. I feel like it's time to take a break. I'm going to condense this down to fully 3 hours and 40 minutes. But when I come back to this material in part 2, I'm going to address more renal pathology, starting with the contents of a urinalysis, then discuss glomerular disease such as nephritic, nephrotic, and nephritic-nephrotic syndrome, and then I'm going to dive into all of the sources of. Then I'm going to talk on kidney stone and hydronephrosis, renal cell carcinoma and oncocytoma, nephroblastoma, transitional cell carcinoma, so all of the tumors, as well as squamous cell carcinoma. Then the sources of incontinence and infectious diseases that affect the urinary tract. I'm going to talk more in detail on kidney injury and consequence of renal failure. I'm going to talk on renal osteodystrophy and tubulointerstitial nephritis, tubular necrosis, diffuse cortical necrosis, and renal papillary necrosis. I'm going to talk on renal cyst disorders, and then pharmacology. So mannitol, acetazolamide, furosemide, bumetanide, torsemide, ethacrynic acid, thiazide diuretic, such as hydrochlorothiazide, chlorothiazide, metolazone, spironolactone, clarinone, amiloride, and triamterene, potassium-sparing diuretic. And then a little bit more on ACE inhibitors like captopril, enalapril, lisinopril, and ramipril. The angiotensin receptor blockers, the ARBs, like losartan, candesartan, valsartan. And then I'm going to finish it up with lesprin, which is a direct renal inhibitor. So that's on the program for tomorrow. God bless you. Stay strong, girl.